All right, everyone, welcome back to the show. I'm Dr. Daria Hamra, your host, and today's conversation is going to change the way you think about aging, health, and the most overlooked transition in women's lives, which is, I'm sure you all guessed, menopause. My guest is none other than Dr. Mary Claire Haver. I'm sure you've heard of her through social media, and she's been on many podcasts recently in the past year. Who is a board-certified OBGYN and certified menopause provider and best-selling author of her book that she published last year, The New Menopause. This is more than a medical discussion today, so it's a wake-up call, a re-education, and a movement to empower every woman to step into this next phase of life with strength, with clarity, and science on her side. Whether you're a woman going through it, or a spouse trying to understand it, or a practitioner seeking to treat it better, you need to hear this. So let's dive into the conversation on menopause, one that's really long overdue. So I want to start this by a quote, with a quote by Mark Twain, who says, "The two most important days in our life are the day you're born and the day you find your why." So, Mary Claire, what is your why? Why did you take time out of your busy practice in life to write this book called The New Menopause? And why did you call it The New Menopause? Is there an old menopause?
So my why is realizing that I spent 4 years in medical school, 4 years in residency, and probably 18 years in clinical practice. And I knew more about the bottom of the ocean than I did about menopause and health in women. And that just became my why and my passion, because sadly it took for me going through my own menopause transition and just absolutely, I thought I'd be one of the lucky ones who would have this whisper of inconvenience, but it was a storm that completely took me out. And I just thought, if I'm sitting here suffering, what are all the other women doing? I can't be alone in this. And you know, I realized that so many patients were trying to tell me, but I didn't know how to listen. I didn't know how to connect the dots between every organ system that is affected by the change in hormones in the female body. Just, we were never taught that.
Is it something that happened suddenly, or did it creep up on you and you just didn't understand how to interpret the symptoms and put two and two together? I mean, you talk about the storm, but did you see clouds on the horizon and wondering where they're coming from and when they're going to get here? Because obviously you are a board-certified OBGYN and you knew, and then even knew one or two things about women's health.
So now that I look back, there were clouds on the horizon, but I didn't know how to recognize them. I rewarded myself by being the busiest person I knew, right? I was a mother, raising children, working as an OB-GYN, you know, all of us who take on these incredible roles in our lives. And there was no time for me to have downtime, but something was changing. Another thing was I was on birth control pills to control polycystic ovarian syndrome. So I realize now that most of probably the overt symptoms were masked by the fact that I was taking hormones for a different reason. And I got off the pill at about 48 to see where I was hormonally, and that's when the symptoms hit me like a train. I wonder if I hadn't had that kind of abrupt transition, you know, if I would have been so motivated to, you know, get to the bottom of this, had it been less dramatic for me.
But my point is, the symptoms that you're describing, how are they same for everyone, or they're different? So can you walk us through the symptoms? First of all, your personal symptoms, if you want to share them, and then the most common symptoms that are overlooked, not just by the patient, but also by the primary cares and the OBGYNs, by the medical system. Because that is very important for women listening.
In my training, I was taught that menopause was hot flashes. About 85% of women would have hot flashes, and most of us are taught that. We all know that it is a hallmark. And it's interesting because that is a symptom that's hard to blame on something else.
Sure.
Right? So most of us know menstrual irregularities, hot flashes, genital urinary syndrome, but only like later, like older menopausal ladies will have dry vaginas and stuff. I never was taught that that could start in perimenopause. And we knew that down the road, osteoporosis might be a factor as well. And that was it. I had no idea that menopause affected the brain, affected sleep, affected our liver in the form of changing our cholesterol numbers, affected our insulin resistance, affected our musculoskeletal system. The greatest acceleration of bone loss and muscle loss is in perimenopause. And I didn't realize that menopause was the turning point for the dramatically increasing risk of cardiometabolic disease. And so just, taking a woman through the menopause transition increases her risk of metabolic syndrome 2 to 3x, if you age match them.
And so how is the general medical community responding to these symptoms? And compared to from 20 years ago, I know there was a study relating hormone replacement therapy, for example, to breast cancer. And that obviously omitted a lot of women from getting proper care when it came to replacement therapy. How is today different? Because there is not, I would say 1 or 2 patients a month or even a week that come to me that have the symptoms when I ask them if they have discussed hormone replacement therapy with their patients. Either the answer is no, or they say my doctor doesn't recommend it because of the risks. And this is 2025.
Yeah. So so I have a daughter in medical school. I was a residency program director until 2018. So there's a little bit of a gap, between when she started school, what I know they're being taught now versus what we were teaching up until 2018. And it was that hormone replacement therapy for most patients, the risk would outweigh the benefit. And that theory is based on the very outdated one study that did not reach statistical significance in 2002, changed the course of women's health outside of reproduction for decades. And when you think about that, there have been multiple looks back at the study. The data has been walked back. For the vast majority of patients, especially starting early, the benefits will far outweigh the risks. Her quality of life will improve. She'll live longer. She'll have less cardiovascular disease, less osteoporosis, less dementia. And most docs have not gotten the message. Now, this is not the fault of the individual clinician. This is the fault of the system. Women's health has been overlooked and undervalued outside of reproduction. When you look at time and training, NIH funding, all of the critical, ways that we measure what matters in health and how we're going to teach educate our clinicians, women's health outside of the breast and uterus is almost non-existent. Like how we disease differently, how we have cardiovascular disease, how our bones deteriorate quicker, how we have increasing rates of dementia. Those are just classically understudied.
So wasn't that study debunked though 10 years later? And I mean, we're talking about at this point,
multiple
10 years.
Have come back and walked back. But it went viral before there was viral, right? It was the number one medical news story of 2002. It was on the cover of every paper. It was on NBC Nightly News.
Remember.
It was on Good Morning America. I remember I was the chief resident the year it broke, and we were terrified. And all we heard was estrogen causes breast cancer. That's not even what it said, right? It was the estrogen and progestogen arm, which is a synthetic progestin, which none of us use anymore, had a non-statistically significant increased risk. And it was a relative risk, not an absolute risk. The absolute risk was minimal. And so therefore 80% of women threw their prescriptions in the trash. They were absolutely terrified. Everyone bought into this notion that somehow the natural hormone our bodies make is somehow trying to kill you. Where in pregnancy, when we have the highest levels of estradiol floating around our bodies, breast cancer is almost non-existent. It happens, but it's extremely rare. And the most likely time we're going to get breast cancer is when we have no estradiol in our systems. It just, when you think about it logically, it really doesn't make sense.
So where do you think the medical system has failed in that they didn't make the debunking of those old studies viral enough so that it would penetrate
So
the medical system?
guidelines, it takes 17 years to change a guideline. You know that, right?
Yes.
And so the guidelines, like the American College of OB/GYN guidelines today, it is 2025, say the lowest dose for the shortest time possible. That is based on nothing. There's no clinical evidence to support that. The Menopause Society guidelines say it's completely different. Benefits outweigh the risks. Keep her on it as long as for her, the benefits outweigh the risks. There's no age at which you must need to stop, right? It will always protect your bones. And it's FDA approved for the prevention of osteoporosis. So our guidelines are not agreeing across different medical specialties.
Yeah.
Like there needs to be, no one is in charge. There are no adults in the room when it comes to women's health after reproduction ends. So once we're done having babies, no one's in charge.
Well, the fact that there is a menopause society and then there is the OBGYN society,
right.
that in reality they should be one society. I mean, menopause is, as far as I remember from basic biology, is part of women's health.
But I mean, think about it. Should the poor, busy OBGYN who's a part surgeon, we're wearing so many hats, really be in charge of the whole shebang?
No, I agree. So I agree in subspecialization, but to the very least, they should be aware of that. They should agree on one type of treatment. They should know the symptoms, and they shouldn't poo-poo or minimize the symptoms and the necessary treatment for menopause, so they can at least channel the patient appropriately and answer their questions. So at least they should have the same message. They shouldn't necessarily treat them, but they should have the same message. And that is the thing that is bizarre. Like, why has medicine gone so siloed that two specialties, or a subspecialty and a specialty, can communicate? And we see that throughout medicine. This is not just for OBGYN menopause. This is for all specialties and subspecialty. There is this tribalism going on, almost this false sense of pride where, sometimes I ask myself, why are we even in this field? We're in this field to serve patients, not to... I don't know. To be honest, I don't know the reason. But here's the good news, Mary Claire. I think people like you or the internet, social media, they have raised patients' awareness where they are now able to look things up themselves so that they can ask the proper questions. And if they don't get the proper answers, they can then make a decision. They have a choice to go seek a different opinion. I think this is the era of empowerment. I think social media, even AI, significantly have empowered the patient. And the other downside is the distrust in doctors now. I mean, that isn't on the rise. I mean, we can't deny it.
That is undeniable. And it is a shame because most doctors are amazing and wonderful human beings. And the lack of knowledge and education around menopause is not that doctor's fault. They're doing their best with what they were taught. They're overscheduled, overworked. I never want to say, there are bad apples. They're in every walk of life. But I think, most people went into this to help people, and they're really trying to do their best job. And what's happening in medicine as far as the corporatization and the administrative burden put on the physicians, to see more patients in a shorter amount of time. I mean, menopause is complicated. It's hard. It mirrors so many other diseases. How can you do that in 10 minutes with your feet in stirrups?
I mean, you're being very kind by saying that. You put it in a very kind way. I'll be a little more direct, because I feel as physicians, we have, because we're dealing with people's lives, we have a bigger responsibility. It's more of a calling than blaming the system. I feel I kind of don't agree with that, because you're basically leaving the door open for anyone with an excuse to walk through. And I think we have a greater responsibility. To the very least, don't tell the patient that hormone replacement therapy is bad and they're going to get cancer. Like that's where I would draw the line.
That's a problem.
You can't. There's no excuse for that. I agree with you when you say, well, it's they're overwhelmed. They can say, well, I'm not an expert in it, but I can refer you to someone, to a
That,
menopause
right.
specialist.
You don't have to
But
practice menopause care,
yes,
like,
but to scare the patients and do fear mongering, I mean, that
yeah.
is complete misguiding, and that's where I draw the line. And for me, there is no excuse. And based on the science today, it's borderline malpractice because. Let me ask you a question. Maybe you can answer that. How many relationships, if you give me a percentage? Now, we know, I think it's something like 70% of marriages, they end up in a divorce. I read that somewhere. I think after
I think 70% are initiated by women. It's a little
right.
over 50 that end up
So,
in divorce.
okay.
And
So do you think menopause has anything to do with it?
absolutely. And not in all cases, of course, but I have two or three, four good friend patients who are divorce attorneys, and they love to talk about this. So they give me all their opinion on everything because they are in it every day. And they say two things happen. One, she circles the wagons around herself and says, this was not a relationship that was serving me. I've got 30 more years to live, and I'm not going to live it with this guy. Okay. There's something about menopause that gives you the power and permission to put yourself first. So that's like some of the divorces. But others are, she is going through a massive transition and overhaul. And her whole life, the way she looks at things, the way she's reacting, we see a tremendous loss of intimacy. At least 50% of my patients are suffering from decreased libido, meaning they miss it. They had it. They had a healthy sex life that they loved, and they miss it. It's not there anymore, and they love their partner, and it's not a relationship issue. That can destroy a marriage. They're emotional. 40% of women have an increase in mental health disorders, so across the menopause transition. And so all of these things, she is changing, he is not. And that's going to create a disconnect in a relationship. And that might be part of the divorces as well. So the divorce attorneys are like, if we treated genital urinary syndrome of menopause, if we treated mental health disorders in perimenopause, if these weren't a thing, if this was like nipped in the bud and we get all these people, taken care of, how many divorces would we avoid? And they think a lot.
I know. I mean, geez, I don't know if they've done a study on that, but it's hard to do a prospective study, but at least like a retrospective study where I had just had a patient last week, literally. I took her medical history and I saw she's on hormone replacement therapy. I'm like, so it always impresses me. I'm like, okay, I asked them, who's your doctor and how did you find out? How long have you been on it, etc. And she looked me in the eyes and with tears in her eyes, she said, it saved my life. It saved my marriage. And then she looks over to her husband and they both, start hugging each other. And I'm sitting there. I'm like, okay, do you want me to leave you guys alone? I can come right back. But that's when I realized how important this is for relationships. Not just for a woman as a self-empowerment or health tool, but relationships. And that's why I asked you that question, because until I saw that couple, it wasn't on my radar. I didn't even think in that in those terms. I was just thinking in health terms. Now, if you're a woman listening to this, what can you tell them as far as symptoms to look out for? And before you maybe say that, can you describe perimenopause,
Sure.
the process of perimenopause, how it leads to menopause and postmenopause, so that women that are listening in all groups of ages can understand where they are, and then they can correlate those symptoms.
So menopause is when we run out of eggs. So human females are born with our entire egg supply. We have about 1 to 2 million at birth. And then then we go through a process called atresia, which is survival of the fittest. The healthiest eggs live, and the weaker eggs kind of die off at a very quick rate. So by the time we're 30, we're down to about 10% of our egg supply. And by the time we're 40, we're down to about 3% of the original egg supply. And menopause represents the end of eggs. ovulation and the production of our sex hormones, which is basically estrogen, progesterone, and testosterone. Now, we have other sources of testosterone, so I'm going to leave that out of the conversation for now. But estrogen and progesterone, ovulation begins in the brain. So we have a gland in our brain called the hypothalamus. You and I know what it is. And it is always looking for estrogen. There's a little wire, just pretend, that goes into the blood and is like, where's the estrogen? So when estrogen levels start dropping off after ovulation, it says, whoa, I want more estrogen. So it starts sending signals to the ovary. It's basically something called GnRH talks to our pituitary gland. Pituitary makes LH and FSH. Those go and bind to the cells around the eggs to create estrogen and then progesterone after ovulation. So we have this beautiful EKG-like ebb and flow of our monthly cycles in a healthy woman who is pre-menopausal. Okay. Month after month, on day 12, you're going to do this. Day 18, you're going to do that. Now, if you have hypothyroidism or PCOS, this is not you, right? But this is a woman who has a normal monthly cycle. Here comes perimenopause. The brain detects low estrogen. The signals go to the ovary, but we don't have enough eggs to respond like we used to. So the brain is like, hey, I should have gotten my estrogen by now. I don't see it. Starts pumping more and more hormones from the brain to the ovary. So that FSH and LH gets higher and higher and higher. Boom, we get the ovulation. We get these surges in estradiol much higher than we ever did in our normal menstrual cycle. So what used to look like an EKG now becomes very chaotic. We have delayed estrogen, very erratic, sporadic ebbs and flows, and progesterone never kind of catches up to where it used to be. So I call it the zone of chaos, and it becomes more and more chaotic until the whole thing is like a jalopy and just until you're out of eggs. And that is full menopause. That chaotic zone can last 7 to 10 years. So before your cycles ever become irregular, the brain knows something is wrong. So in perimenopause, quite often, the first signs and symptoms that we see begin in the brain: sleep disruption, mental health changes, cognitive changes, and brain fog. Periods are still regular, but the brain is working harder and harder, which is affecting our levels of neurotransmitters. Okay, serotonin, dopamine, norepinephrine, all of them start becoming a little bit more erratic. So the brain doesn't function as well. So 70% of us will complain of cognitive changes, 40% increase in mental health disorders across the transition. Now, those are the people coming in complaining and getting a diagnosis. Imagine how many people never said anything and just kind of dealt with it. So perimenopause, actually, the first symptoms we see are in the brain. All of a sudden, you're not sleeping as well, as deeply. You're waking up in the middle of the night. You're struggling to go to bed. More nighttime anxiety, restless legs. We're just seeing, before your periods ever become irregular. Now, here comes the joint pain. Here comes your elevated cholesterol. Actually, a beautiful study just came out of, I think it's China, somewhere in Asia, where they're looking at small, dense LDL particles as a marker of perimenopause, because we don't have a good blood test for perimenopause, but it looks like tracking this one particular LDL particle is going to be really good because it doesn't increase with age, only with menopause.
Is that why women post-menopause are at higher cardiovascular risk?
Yes. So across the menopause transition, like I said, 2 to 3x syndrome. So we lose the elasticity in our endothelium. So we have increased blood pressure. Okay. So the arteries. So our arteries become stiffer. So we have elevated blood pressure. We have much higher levels of insulin resistance and prediabetes, and of course, then diabetes. And all of that leads to, and of course, our LDL goes up, our HDL tends to decline. LDL goes up higher than HDL drops, but all those three together is the trifecta that leads to increasing risk. And there's this anti-inflammatory property of estrogen that decreases the rate of plaque deposition that you see in a premenopausal woman. She's protected against that accelerated plaque deposition where she loses that and when she becomes postmenopausal. So we do lag behind men for about 10 years in the risk of cardiovascular disease once we go through menopause, but then we pass them up.
Interesting. So and that's the reason why our endothelial cells have estrogen receptors, right?
Yes.
And that's
why. That's what we think.
Interesting. So at what point then in the perimenopause should a woman adjust her hormones with actual HRT?
Well, this is all expert consensus because there's not been a single large study done on the treatment of perimenopause. Nothing. We have nothing.
That's shocking.
So it is a bunch of experts who get together and like my friends on our group chat on WhatsApp, the menopause, and like, how would you treat this? What if she comes in with this? So we're like, okay, early perimenopause. She's still cycling regularly. She's having mental health. It really have to look at it symptom by symptom, but really the sooner the better. We know for mental health, the sooner we support the estrogen, the better. We know for sleep, and especially for cognition and risk of long-term dementia, the earlier you treat, the better, including early perimenopause and for cardiovascular disease risk.
And then let's say you haven't gotten the early treatment, and what is the current consensus in initiating HRT treatment?
So it depends on what you're trying to prevent, right? HRT is not FDA approved for prevention of anything.
True.
Except for osteoporosis. But the U.S. Preventative Task Force has not, again, they're not all agreeing, right? The Preventative Task Force. So like people who are in the old menopause are saying, well, the USPTF is not recommending it, so we can't recommend it. Yet the FDA has approved it for prevention of osteoporosis. So you know what? I'm just going to do what's right for the patient. And if she wants to prevent osteoporosis, I'm going to talk to her about this is the most effective way to do it. Is hormone replacement, is not be menopausal. And we have an artificial way to do that with hormone replacement therapy. If she wants to prevent cardiovascular disease, that's different. Estrogen is better at prevention than cure. So you need to get it on board before she develops those calcified plaques. So the only way you know that in an older patient with risk factors is to get a calcium cardiac score and then use that number to help guide your treatment options. So I can't promise her cardiovascular protection after the age of 60. Now, maybe if she doesn't have existing cardiovascular disease, we may be able to get her a few years, but starting the younger, the better.
So let's say 10 years after menopause, you see you're 10 years post-menopause, and they say, these studies show that ideally this works if you do it within the first 10 years, correct?
Right.
Does a woman get any benefits if they do HRT after
the age
that
of 60?
time? Yeah.
Certainly if she's still symptomatic as far as vasomotor symptoms, yes, she will have benefit. No doubt. No one's arguing with that. There was a great study that came out, looked at Medicare beneficiaries who were continued on HRT after the age of 65. Okay. So women who kept going after 65 had lower all-cause mortality. They lived longer. They had less cardiovascular disease and less dementia. So that, is something worth paying attention to. Hot flashes are the bell ringer of stroke, cardiovascular disease, and diabetes. And so if she's still into her 60s and having hot flashes, I can't promise we're going to prevent those diseases, but you want to prevent her hot flashes.
Interesting.
Because she's not sleeping.
Right. Well, I mean, I think anyone listening to this either knows someone or is someone that has these symptoms in menopause or post-menopause. I mean, it baffles me why we don't have enough studies when it's the most common symptom.
It's 100% of it.
It's the most common. Yeah, right. So, and we don't have enough studies. What is it because it's not doesn't have enough incentive for pharmaceutical industry? Is it because
that is a problem, right? So the NIH, they had $1 billion grant. It was the biggest study in women's health ever, was the WHI. We were so happy and so excited that women were finally being studied. And then the whole thing got cocked up, right? So then that scared the NIH off of anything clinically reasonable in hormone therapy, right? That not even a discussion. So then you have big pharma, all they're working on are SERMs, selective estrogen reuptake modulators. So things that are, kind of look like estrogen, but work a little bit differently. And we need those. Like there are patients who can't take estradiol or shouldn't because of risks. And so SERMs come in really handy for them. But they're not, and then there's Veoza that just treats the thermoregulatory center in the brain. That's it. It doesn't treat your bones, your muscles, or anything else. It's not the root cause. So, but plain oral estradiol is $2. Nobody makes money off of that. It is $2. So no one cares. It's like, when you look at the economics of it, HRT is cheap. So,
but it's easy. Therefore, it's easy to conduct a study, right? I mean,
you would think, but to get that thing approved is really hard. And I don't want to get into politics, but getting anything approved is really hard. But stepping outside of the NIH, there are still studies going on. Lisa Mosconi has just been a huge grant. It is from a pharmaceutical foundation to look at what is the connection between menopause and Alzheimer's disease. And she's not having to publish, they're not forcing her to publish papers every 5 minutes. She just basically is focused on outcomes, and she thinks she could do it in 3 years. So there is some innovation going on with how we're doing studies. And so I'm really positive about that. And there's still tons of studies going on outside of the US. So don't give up hope,
Yeah, no, it's just, it's sad. There's many fields in medicine that don't get funding. They're so crucial because of that issue that we're talking about. And you would hope at least, there would be, private funding, or at least academic institutions, they would support that just for the sake of medicine and advancing health. And it's just,
this country is about to have the biggest wealth transfer in the history of the world from men to women as this generation dies off and the money goes to their wives. And these women don't buy rockets, and they don't buy jets and yachts. They invest, and they invest in research and philanthropy. So we're hopeful that we'll be seeing more of this kind of research coming out.
Yeah. So what do you, let's talk about some practical stuff for women listening to this. What are some of the things that women can do? By the way, can you, if you don't get hormone replacement therapy, can you do anything through lifestyle changes to improve the symptoms and the progression? Can you kind of give us some practical advice? And you're so good about it on your social media, but I just want for our audience here, our listeners, if you can kind of guide them with very simple, practical things that are doable and sustainable long-term.
So when my patients leave clinic with a toolkit. I'm not just giving them estrogen and progesterone. It's not just a hormone clinic. I don't do that, right? They get a whole lifestyle recommendation. I have a body scanner where I'm measuring visceral fat and muscle mass, and we're having deep conversations around longevity. And I call it nursing home prevention. Women live longer than men, by 5 years. So no woman I know wants to live to 120. She just doesn't want to be in a nursing home. That is our goal. So I'm like, okay, I got you on that one.
Sign me up.
Weightlifting. You know what? Muscle preservation and building muscle. The most geroprotective thing in the woman is the muscle and the ovary, and we lose our ovaries. So those are the two things. So how do we do that? Make sure you're getting adequate protein. So many women are not getting enough protein in their diets to sustain muscle mass. So I didn't. I was focused on weight loss my entire adult life. Stay small. And it's so beautiful now.
Well, and if you go to the gym, you see a spinning class or some aerobic class, it's filled with women, and you go into the weightlifting departments, only men. And there's
getting better.
Is it?
It's getting better. I think so. My generation, they hear the call. Everyone's buying weighted vests. They're joining gyms. They're hiring trainers. They're hearing the message that this muscle is going to protect me from the last 10 years of my life being plagued with chronic disease and frailty. They don't want that. Okay. And they're getting it. Adequate protein, adequate fiber. Most US women in the US are only getting 10 grams of fiber per day. We need 35 to 45.
Fruits, vegetables.
Fruits and vegetables, whole grain, seeds, legumes, nuts. Plants and protein. That's what I tell my patients, especially on GLP-1s. I am like, plants and protein are your goal. Don't look at anything that is what your foundation should be, your protein, and then fill the rest of the plate with plants. We have a 30 plant a week challenge.
Oh, wow.
Can you get 30 different plants in your diet per week?
I don't even know if I know 30 plants, to be honest. I got to look at that. Top of my head, I could come up with 12, but geez, I got to look at that.
So movement, stress reduction,
well, that's easier said than done.
I'm like, girl, your cortisol levels are high. You're a woman.
Yeah.
How are we going to bring them down? I'm like,
don't watch the news. Don't watch the news.
Get off your phone. But take that time to sit in silence, meditate, journal, pray. What is it going to take to bring you back inside of yourself? To me, gratitude journaling changed my life. To sit down and write all the good things in my life every morning.
How do you motivate patients? I do that personally, and I always talk to patients about it. And I realize as soon as I tell them that, their eyes start going to the sides. They think like, this is like woo woo stuff. How is that going to help me? It's easy for him to say. It's how do you get them to actually buy into it? They have to buy into it.
I talked about the time I hit rock bottom, and like I was desperate. I like had to do something because I was going to.
Can you talk to us a little bit about that?
I was in menopause, and I had 2 teenage daughters, and my older daughter, I just felt like I lost her. Like I lost any real connection with her. And this is my daughter in medical school now, like on the surface, it just looked like everything's fine. She's going to go to med school. She's a straight A student. She looks like me, but I just felt like I didn't even know her anymore. And I wanted that back, and I had to stop blaming her for that and look into what I could do. So I got therapy, and I always thought it was woo woo.
Did you used to blame her?
Totally. Blamed her. She doesn't understand. She doesn't appreciate. But then I thought back to my relationship with my mother, which is, not a place I saw she and I heading towards where I am with my mom. And I didn't want that. And I realized I had to change, that she was the kid and that this was me as an adult and my responsibility. And it just, I was risking that relationship with her for the rest of my life. And it was hard, and it was over 2 years, and it's never going to be perfect. But like me working on me changed everything in my life, and made all my relationships better.
How did you do that?
I got therapy. I worked through some of my trauma. I, went through cognitive behavioral therapy. I learned how to self-regulate. My daughter was asked to go into her own therapy, which she did. And I, writing checks left and right for whatever she wanted. And it's so much better, and it's made everything better. And it just really made me appreciate how all of us have something, right? All of us have trauma, but like we've got to come back to ourselves. And I love myself now, and I'm doing good in the world. And one of the most powerful things when I feel like that, I get dragged on social media or have a, colleague, want to take me down for something. What do I know is true? What do I know is true?
You.
I am a good person. My intentions are pure. Maybe sometimes I don't say the right things, but, taking it back to yourself and taking that time to write down what is good about me. And, forever I was always so self-critical. You're not working hard enough. You're not this enough. You're not that enough. And I really think menopause has given me the permission, that gift to give myself, because if I didn't, I wasn't going to make it.
Wow, what a powerful story. And how long did it take? How long was that process? And how's your relationship with your daughter now? Do you guys ever talk about those times? Does she know? Bit. Does she know what you?
She's in the grind. She does.
Because that would be very valuable for her if she hits that point at some point in her life, remembering how it was with her mom.
She's studying for step 1 in the other room. So, she is in the
I hope she's listening now, secretly. She's
Christmas, we were with some elderly grandparents who were really struggling. And I was trying to juggle, cleaning and, all trying to act like everything's normal when we got 2 really, really sick grandparents. And she kind of caught me in the corner, like heavy breathing. And I was like, I'm trying to self-regulate. She said, I see you, Mom. I see you. It's okay. So, and I really felt like that was a connection, like I was like, okay.
And so out of when you share these stories with your patients and you try to motivate them to basically you're trying to make them buy into the treatment, the stuff that they can do. And it's always hard to sell someone a treatment regimen that involves the patient putting in a lot of time and effort themselves as opposed to just a pill, right? I mean, that is a hard sell.
So what I frame is the outcome. And the outcome is not looking good in a bikini or whatever. It is avoiding the diseases that are plaguing her elders. And if she's taking care of an older parent or aunt or grandmother or watch the disease and suffering, she's motivated. I just have to point it out. And then they're like, okay, I'll do anything not to be like that, not to burden my children, not to have the decisions I'm having to make for people who can't take care of themselves anymore. I don't want to live like that.
That's a
That is the
great point.
most motivating thing.
Doesn't it require a lot of self-awareness from the patient's standpoint, though? I mean, don't you have patients that they always blame the outside for whatever misery they're in and don't necessarily buy into an outcome that involves them putting a lot of work in? How many percent of your patients would you say? I want to know your experience, and I'm being a little cynic on purpose.
Yeah,
I want to
no,
play
I get
devil's.
it.
I'm playing devil's advocate here.
Most of my patients follow me on social media. So they've been on a journey with me, right? Because it takes a
Got it.
long time to get in to see
Right.
me. And they
That's what.
follow and they watch and they've read the book. So I'm so lucky
So they're
that
primed.
I'm not meeting strangers. I don't know them,
Yes.
but they're coming in and they know everything about me and what I've said and what I've read. So like that's a little bit unique in my practice because they are already bought in and they just want to know like the numbers.
Okay, let's talk about the time where you didn't have a social media platform.
Yeah.
By the way, when did you start this approach? When did you get into menopause? I know you said like what, 2018 was it?
2018 was when I launched. I started kind of like playing around on social media and women's health, and like 2015 is when my brother died, and when I started working on the nutrition end of the program. And so I was kind of mark everything by then. So it's been about 10 years that I've been doing this. Now, I was growing kind of steadily, and then COVID, I really blew up on TikTok. So that was like the first wave where I hit 2 million like within a year. And then Instagram kind of took over and when Reels launched. And so now we're at about 2.7 million on Instagram. So I have over 6 million across like the big four. Amazing. YouTube, Facebook, Instagram, 6.5 million. So that's been a few bursts, but fairly, it's been tracking for about 10 years.
So obviously it's easier for you to have your patients buy into your treatment because they're already listening to your content. They're already, so to speak, primed. How was it before that, though?
Yeah. So when I first opened the clinic, So, it takes me an hour to see the patient. And I've stepped outside of the third party model. And so I just have a one-on-one relationship without an insurance company telling me what I can and can't do. And I am the boss, which is the funnest thing ever. And and if I need to take more than an hour, I do. But like I schedule a good solid hour of face-to-face time with the patient. So we have time to kind of work through, and I have extensive paperwork they do ahead of time. So I know their family history, their medical history.
Correct.
I know what their chief things are when they get there. And we can really just start drilling down and helping her kind of craft what she wants, what are her goals, and how are we going to meet those.
And so how did you, because that's very interesting we have a huge audience of physicians listening to my podcast. And I'm sure there are many, I personally know them, they're contemplating the transition from going away from the third party model like you have, which can be a little scary. Which is scary because, it's not very predictable. You're not going to, you don't know how your business is going to, or whether or not your business is going to. So how did you obtain the courage to do that? And how was it in the initial stages for you?
So I had always been employed. I had just walked into an employee contract for every job I've ever had. I've had 3, and I just showed up with my stethoscope and my laptop or my iPhone, and went to work.
Clock in, clock out.
Clock in, clock out. Of course, we never clock out. We're
true.
always doing stuff. So, I knew I had good rapport with patients. I knew like once I got them in the door, that would be fine. I took my girlfriends out to dinner, like 6 of them, and said, okay, I'm dreaming of opening this clinic. Would you come? Like, would this be something you would come? We're not going to take insurance. And like, it was overwhelmingly yes. Like, if you don't do this, you have to do this. Like, this is your passion. This is what you're doing. So I got buy-in from my like 6 mom friends, right?
Little
so
micro study.
I did not know how to open a practice. I had to go buy a guide, like the idiots. And I had a few friends in concierge medicine. I didn't want the exact like monthly payment concierge model, but I talked to a ton of people, a ton. I interviewed with a couple of concierge practices, didn't feel like the right fit. And I think I really just want to do this on my own. So my CEO at the time, COO, was like, here, I'll help you build it. She was my office manager. But I didn't need a nurse because I'm not doing physical exams. I didn't need 7 people in the back office running insurance forms. We were just collecting money up front. I mean, I went through the state guidelines to
Sure.
make sure we did all the things, and I threw up a shingle and started advertising on Google and for local patients. And talked about it a little bit on social media. And I had a pretty big email list at the time. So we just kind of, on a wing and a prayer, figured out what it would take for us to break even. What would we want in profitability? How many patients would that take? And figured it out, And so did we make mistakes? Yes. Would I do it a little bit differently? Yes. But now we have, we've bought our own building. I rented for 3 years. We bought our own building. I have another physician and 3 nurse practitioners, and we have a waiting list of over 1,000. So it was profitable. So if anybody out there is listening and you want to do a no third party model, however you want to, decide what you want to charge, so that's reasonable practice, you can do it. Women need this care. They are desperate for this care. I now have patients flying from all over the US to come and see me because they can't find anyone near them who can do it.
I know. That's why before this podcast, I asked you, because I have a lot of women asking me and I have trouble sending them somewhere.
Yeah. Like, you shouldn't flight it. You have to flight it. I mean, I'm honored, but I mean, my God, really?
I know. Yeah, I know.
For menopause. So the Menopause Society has a list of certified providers on their website. That's a place to start. They're not all perfect, but call ahead. We have a resource of recommended physicians on our website recommended by my followers. So we have several hundred that they've written testimonials for, and we've organized them by city and state and country. And then there are great telemedicine platforms out there that are built specifically to take care of menopausal women. I will leave off the ones I don't love. So I'm going to talk about MIDI Health, Alloy Health, and Evernow. Vetted all 3, looked at their treatment protocols. They're legit and very, very reasonably priced. MIDI takes insurance. So they do use the insurance model if that's the route you want to go. The other 2 are very, very reasonable. So there are options out there if you can't find anyone local.
Are those links on your website for me?
Yeah. Okay. So we have on our website something called the Menopause Empowerment Guide.
I'll put the link for the audience on the.
It's 14 pages long, and it's like questions to ask your doctor, lab tests to ask for, how to find a physician. It has tons of links, basic nutritional recommendations, the fiber, the calcium, the vitamin D, all the stuff that I would recommend in menopause. So that's all there, and it's free.
So where do you see the signs of menopause and women's health going into the next decade? I'm sure you're at the forefront of this, so you're probably the best person to ask this.
So I feel like, I get reports from my daughter. So she's just finished second year. And
is she going to do OBGYN?
She says absolutely not.
Oh, okay.
So I think she'd love to do women's health. She just doesn't want to suffer through obstetrics, right? And so, so I don't know if she likes psychiatry or internal medicine. We'll see. She hasn't done her wards yet, so we'll see what she ends
Well, at least she went into medicine. None of my kids are interested in going. It's like, okay.
Well, my other baby's doing PR and marketing. So,
oh, nice. That's exciting.
She went the other direction.
That's yeah. So the next decade,
I feel like it's probably a decade away from a woman being able to confidently walk into her clinician's office and expect to have a reasonable conversation. We just are going to have a big train and lagging in education. Even who just were never taught. Even
with social media and AI, you think it's going to take a decade?
Well,
that is so depressing.
6 months to get up to speed and reading and understand. I mean, my book is written for lay people, not clinicians. The Menopause Society, they only certify twice a year. So it takes about 6 months. So who has that time when we're all busy clinicians, But if you have a special interest and you want to carve out the time, you have to go outside of your training to be able to do it.
So you think just the access to people like you is going to be the limiting factor, not the information.
Right. For now. Yeah. To find someone who's comfortable.
Are you serious?
Yeah.
That is the most depressing news I've heard. I don't know. All year.
There's, the telemedicine platforms are growing. We're have stopgaps, to get us through, but we're going to have to retrain our practicing clinicians or give them, it's going to take months. It's not a weekend course you go take and you're menopause certified. It's hard. Because it's every organ system in our body. Yeah. Some days I'm a psychiatrist or an internist or an or a rheumatologist.
So what about these concierge practices, these primary care medicine physicians that have concierge practices? They They spend a lot of time with the patient. I mean, I feel that should be their purpose in a way, because they have already the business model. So knowledge can't be an excuse for them.
Did they get the training? Did they go outside? If they're depending on what they learned in their residency, they most likely have not received adequate clinical training to take care of menopause.
Oh my gosh. Well, that is not very good news. I did not expect that.
Yeah. But we'll get there.
So where do you see the role in men in this? How can men support the women, their wives, their spouses? Have you thought about that? And do you involve men or the spouses?
I tell you, my best visits with patients are when their partners come in. So, and because the partners who usually venture into a gynecologist's office are there because they care.
Mm-hmm.
No one wants to be in my office with me unless they have to be there.
Interesting.
And so they are coming from such a place of they love this person. They want to understand this person. They understand that this person's been hijacked by this hormonal shit, by this natural transition. Mm-hmm. And they want to understand so that they can be more supportive. So the best podcasts are going to be this one. When I'm interviewed by men, it's a really different vibe than when I'm interviewed by women, because you're coming at it from a place of understanding versus someone who needs to share their story. And there's nothing wrong with that. Mm-hmm. But I feel like my, armchair expert, Steven, God, I've done so many with just guys, that those are better for guys because they're asking the dude questions, and it really helps get your mind wrapped around what she's going through.
And, the reason why I'm asking is because, the part of the of menopause, the psychological and the sexual aspect of menopause that affects couples and affects relationships. I mean, there's couples and marriages where they love each other, but, psychologically, or the women, because of hormone mismatch, the desire mismatch, as well as, depression,
atrophy, things aren't,
all of those will
orgasm, the frustration.
And then the men might not understand. They might blame either the spouse or blame themselves because they don't understand what's going on.
Right.
So, how do you, it's almost like a sort of a couples therapy that you have to sometimes do, don't you?
Sometimes.
Or you just refer that to the couples therapist and you just focus on the medical aspect?
If they're coming into the office, they are coming to learn. They are coming, they're not coming in for me to be the referee, right? They just want to understand. And so it's less therapy for me and more education and like, how can he help, And really it's coming at it from a place of understanding. This is not her fault. A lot of this is fixable. A lot of this is going to evoke a change, and can you adapt to this?
Mm-hmm. Yeah. I think that mismatch is what's in between a lot of relationships and, the lack of understanding from the self-awareness from the women's side, but then lack of understanding from the men's side, not understanding that these symptoms are not related or a result of, them being the cause and the fault, and rather a medical condition, a physical condition. So any advice you want to share for women that are cynic, are really set in their ways to believe their physicians that told them,
listen to your body. That for the vast majority of patients, menopause hormone therapy is safe, but it's not in a vacuum. Lifestyle is very important. Prioritizing yourself, your needs, your wants, your sleep, limiting alcohol, making sure you're getting enough exercise, all of those things are helpful. But, if you've been told you can't take hormones, they don't believe in hormones, it's going to kill you. You need to, it's okay to change doctors. Even if it was a great doctor who delivered your babies and did great care, there is definitely some bias there that women tend to, I grew up in the medical system where I was taught that women tend to somaticize psychological disorders. This is never true. This is not true. Women are having very real physiological symptoms due to this complete overhaul of their hormones, and just dismissing it as aging, or just, she's being annoying, or this should just be a whisper of inconvenience and she's just being dramatic, is a mistake, and you deserve better.
Last question, Mary Claire. What would you tell your own self when you were a OBGYN resident who just is about to graduate next month and so excited about taking on the new chapter in your life and practicing OBGYN and thinking you're going to help a lot of women with their health?
I would tell her, there are gaps in your knowledge. You've learned so much, so many beautiful, wonderful things, but you don't understand what happens when the ovaries stop working. And this is something you're going to have to learn to understand, or you're not going to help your patients. Because I'll tell you, I was a terrible menopause doctor for most of my career, to be absolutely honest. When I think of the words that came out of my mouth, the things that I mirrored and parroted I'd heard from other clinicians: just have wine, just relax, this will pass, estrogen might hurt you. We're only going to give you this if everything else fails. All the patients I put on Neurontin and Clonidine and, for their hot flashes because I was terrified of estrogen. I'm sorry. I didn't know what I didn't know, and I'm making it my job in life to undo that harm that I did to patients.
Wow. So I hope your colleagues are listening, and the freshly graduating OBGYNs are listening, and I'm sure they are. But that was Dr. Mary Claire Haver, and I hope this conversation gave you more than information. I hope it gave you power. If you're going through menopause, just know you're not alone. You're not crazy, and you're definitely not invisible. And be sure to pick up her book called The New Menopause, and share this episode with a friend, your partner, or even your doctor, because you need to spread awareness, shift the narrative for sure, and bring women's health into the spotlight where it belongs. And whether you are a plastic surgeon dealing with women that want to help them with their transformation, a health and wellness doctor, a personal trainer, a nutritionist, a primary care, or an OBGYN, I think we have a bigger responsibility, and it's our duty to do our research, obtain the knowledge so we can best help them, and rather than blaming the system or throwing our arms helpless in the air and blaming the patient for lack of motivation. So thank you, Mary Claire. Truly honored to have you on the podcast, and keep it going, please.
Okay. Take care.
Thank you. Take care. Bye-bye.